name is Cesar Bañuelos. I'm a local pharmacist, physician assistant, scientist, and hope to be certified pretty soon from the Society of Infectious Disease Pharmacists in antimicrobial stewardship. This is the first part of a two-part series discussing coronavirus um, and trying to figure out or trying to appease some of the concerns, worriments associated with the virus and the vaccine. And I hope to kind of bring knowledge forth regarding these two topics. And so let's kind of push forward already. So the this is just a disclaimer that basically providing you guys with some information regarding the current disease state, and hopefully it helps out. So the elusive severe acute respiratory syndrome coronavirus 2, or SARS-CoV-2. There actually was a SARS-CoV-1, which was around, if I'm not mistaken, in April of 2003. And basically, this is a better version of that original virus. And right, what you see here is there's three graphic representations of the virus itself. And the first one is an electron microscope image. And the most important thing that I want you to look at are these spikes. The spike protein is basically what's showing here in these spikes. If you look at the center image, that's actually the red markings that you see on this graphic representation or this 3D model of the coronavirus. And if you look over here, these rosebuds are actually the spike protein itself. So that's actually spikes. It's made of two subunits, S1 and S2. And so and I'll show you a picture of what the S1 and the S2 look like. But there's also some important things that you need to realize when you look at this. The membrane is going to be very important when we talk about the structural integrity of the virus. But also the RNA is also very important. Without the RNA, the virus basically is useless. It cannot do anything. It cannot replicate or make more copies of itself. It cannot produce the proteins like the spike protein. So essentially without the RNA inside of the virus, it doesn't do anything. It's innocuous, right? So let's push forward. So this is basically going to show you, so this spike protein that you see here, this is the S2 and the S1 unit, just so you can know. This receptor is these two, this locking key, that's kind of going to be the important thing that I'm going to talk to you about. This locking key is what basically causes the virus itself to bind to a cell, come into a cell, replicate, create copies of itself, and then send it out, thus building an army of viruses to fight us, to fight against us. So basically, the virus is floating around. It be transmitted through respiratory droplets or through aerosolization. That's open to interpretation. But so basically, the the virus is floating around. It comes into our respiratory system, and it basically attaches in the form of a lock and key to the ACE receptor, the ACE2 receptor. So if you look over here, that's basically what we're looking at, these spikes right here. The spike has something called the receptor binding domain. It's a special section of the spike that binds to the ACE2, and it basically pulls it into the cell, as you see here. So the cell, the virus comes into the cell, and then it makes copies of itself, and then the copy is released into the body. When I talk about lock and key, so think about the spike protein as the key, and then think about the ACE2 receptor as a lock. In order for the door to open for the virus to come into the cell, the spike it has to bind to the ACE2 receptor to come into the body. Now, the spike is super critical. It's important for it to, fuse to the cell so that it comes in. Without the spike, it's kind of like, well, I don't know how it would function. So And then the important thing that you look over here is that once the virus is floating around in the body, there's certain cells. Um, the one example right here is an antigen presenting cell, this thing that kind of looks like an octopus. The immune system can only recognize bit and pieces. It cannot recognize something whole. So for it to mount a defense, it has to break it down into these little pieces. So that's why what you see here are these little pieces that are being presented to this helper T cell, also called the it's called the CD4 cell, and it basically it presents it to the CD4 cell so that it could essentially, be a mediator for the other cells like the B cell and the cytotoxic T cell. The B cells basically create through another process, but it helps create antibodies, and antibodies are basically neutralize the coronavirus or the SARS-CoV-2 virus. So antibodies are critical, but they're not the most important thing. They're important, just like the T cells are important. So, but so let's kind of move on. Uh, so let's talk about the virus. One of the big things about it is right now, why is it running rampant? We had this dip in the summer. It kind of went, we had a little bit better, response, and then all of a sudden it started to peak. We can blame pandemic fatigue, but there's other things as well that we have to think about. These are hypotheses. These are, things that, based on what we've looked at in other viruses. So what we know for for right now is that the SARS-CoV-2 virus likes cold, dry conditions, and it doesn't like to be in the sun. I remember looking at something over in about May, where the government did some studies on, its survivability on certain surfaces and how, if it was exposed to UV light, what happened if it was exposed to a certain temperature, what would happen, and that's kind of set the groundwork for where we are now. So we know for sure that it doesn't like sunlight. It doesn't like really high temperatures, certain temperatures, and it doesn't like humid conditions. And so those are key factors. So um, so we've already talked about that it spreads through droplets and aerosols, right? And based on the size of the droplet, it can also determine how far it can go. So but in a nutshell, let's kind of just move forward. So, warm and wet climates, not good for the coronavirus. Cold and dry climates, good for the coronavirus. So, we're currently in a cold, dry season. So, that's kind of why we can possibly see the virus surviving or transmitting itself a little bit better right now. So, we talked about sunlight. So, it doesn't like sunlight, and it doesn't really like temperatures, especially temperatures that are 104 degrees Fahrenheit. And as a matter of fact, before we put mitigation procedures into place, there are some countries that hadn't followed suit yet. So there was a study published, and what they noted was that the countries that had higher or had less UV light, those actually were more. That's where the infectious rose higher, was the ones that didn't have a lot of UV light. So it's pretty interesting to note. And and then temperature. So temperature is also a key factor. We talked about 104 degrees Fahrenheit. So there's also something important about the virus. So this white circular portion is called the viral envelope. And just basically, it's structurally important, among other things. But so it's created of a fatty or lipid membrane, and it has, fats all around that area. So what we know from the influenza virus is that uh, at certain temperatures where it's above freezing or below, a little bit above freezing or below, we see that the virus, like the influenza virus, starts to gel up or become hardier or thicker. So we can kind of apply that knowledge to uh, an to the SARS-CoV-2 virus by essentially thinking, well, it could create a thickened outer coat, and that could possibly make it harder or more thick. So to put this into perspective, I would bring upon the elusive or the the biggest thing that I remember was when I was younger, my grandmother having a little bottle of bacon fat sitting on the counter, and it would change consistency as the day progressed or different seasons. So sometimes it would be very thick, and other times it would be liquidy, like you see on the right hand side. And so if you think about it, it's like heartier when it's like cold, but when it's warm and hot, when it comes right off the frying pan, it's very liquidy and flows. So so you can see that they're just the sheer changes can affect the virus. And so this is looking at temperature. So if and this is on different surfaces. So if we look at stainless steel, and we look at the temperature, so the circle is 20 degrees Celsius, the 40 is 40 degrees Celsius. And so as we increase the temperature, it doesn't survive as long on these particular substances or objects. So on stainless steel, if the temperature is 20 degrees Celsius, it would last somewhere between 28 days. But if we went up to 40 degrees Celsius, we'd probably see a day's worth. And that's other things. Cloth was really interesting. So cloth actually doesn't last that long, but on other surfaces it does last. So heat gets rid of the virus, which is important. Humidity is also, so if it's humid in the air, it's not going to like it. But if it's dry, then it will like it. And that kind of happens because when the air is dry, the droplets themselves tend to evaporate a little bit more. So, so these droplets become smaller because the water content decreases. So they're in the air longer. When they're in the air longer, that means they're more likely to be transmitted to another person, or their transmissibility increases. So we can expect a higher viral load because there's more in a certain area. So I would liken this to like a person that's trying to get ready for a special event, and they want to take some kind of medication or over-the-counter supplement that would help them diurese themselves so that they're able to fit into said outfit for the event that they want to go to. And so that's kind of what happens. So it shrinks the droplet so it's able to last longer in the air. And so something that has a lot less weight can kind of float around a little bit more in the air, kind of like if you look at a feather, and you have the feather and then you have the bowling ball, and so the bowling ball will likely fall faster than the feather. And This is an experiment. This is actually looking at an experiment that looked at exactly that. So as we increase the temperature and we increase the humidity, the virus tends to dwindle and go out. So this is basically just 24 degrees Celsius, and then as we increase the humidity, the amount of time that the virus is around is a lot less. So and then if we look at just temperature, so if you look at temperature, we look at we have a relative humidity of 60%, and then we're at 24 degrees, but we just spike it up to 35 degrees. That kind of changes it. So it can go from anywhere that looks about to be 9 hours to about maybe 1 or 2 hours, give or take. So just doing humidity and temperature, all that kind of affects it. So it's interesting because they created a mathematical model. The wonderful scientists at MIT created this mathematical model that's able to put all these factors into place, such as masks, room size, ventilation, humidity, the crowd size. And then, so just some examples of what would happen. So if we had if we put 10 people in a room for dinner in a 20 by 20 foot room, they have normal humidity, they speak the same volume, they don't have masks on while they eat. The safe time for them is about 18 minutes. And then if you add on a coarse cloth mask, that jumps up to 20 minutes. If you switch out if you open up the windows and you increase ventilation, that moves it up to 26 minutes. But then if you switch out the masks and you actually put, surgical grade masks, you jump up to 2 hours, and so, and then you can even adjust it to like, okay, well, are they wearing the mask properly? And then that will basically affect that as well. So if they don't have it on, appropriately, that kind of brings it down to 32 minutes. And so then if you want to go to Walmart and then there's one person in that Walmart that has COVID-19, it's a 180,000 square foot facility. How safe are you when 1,000 people in that Walmart have cotton masks on, but one person in that facility has COVID-19? How long could you safely be in there? It's about 68 minutes. Now, this is just a mathematical model. It's a hypothesis. This is not an absolute thing, but it kind of puts things into perspective. The only drawback with this mathematical model is that it's only accounting for one person with COVID-19 in your situation. This is I don't know who posted this, but it kind of it's a strong argument that I hear all the time, and it says that COVID-19 is not just a flu. And then it says COVID-19 has killed more people in the U.S. than influenza has in the last 5 years combined. How true is that? So let's kind of dive into it. So how come we're not able to treat influenza as effectively as we've treated the coronavirus? Well, that's because the influenza virus is so elusive. It kind of does all these fancy tricks to protect itself. One of the factors is that it does little changes or little mutations in the surface proteins. I don't know if you remember H1N1, but there's other types of H and Ns that exist. But just simply doctoring or changing those surface proteins that are known as hemagglutinin and neuraminidase, just doing those little changes can make it elusive to the immune system, so it makes it difficult to fight it off. But let's put this into perspective, like as far as like influenza mortality or the disease burden itself. So if we look starting from left to right. So left, we have the amount of people that have the illness, and then it's the people that actually go to see the doctor or mid-level provider or any kind of healthcare professional for this disease. What happens? And then are they hospitalized for influenza? And then ultimately, do they die from influenza-related illness? So these are the numbers over the last 10 years. 37,000, 12,000, and so forth. These are estimates because obviously we can't account for every single person that died from influenza, but it gives us a pretty good estimate as to what kind of deaths we've seen in the past 10 years. And so aside from deaths, how effective was the vaccine that year? So we had a great year, 2010 to 2011. We had a horrible year, 2014 to 2015. It's also important for you to look at 2017, 2018. That's when we had a really difficult year when it came to influenza. The vaccine was only 38% effective that year. So going back 2014, 2015, that's when we had a crummy year. The vaccine wasn't as effective. We had 51,000 deaths that year. We had 30,000 illnesses and 590,000 hospitalizations. When it did good, that's actually, we had lower hospitalizations, lower deaths, and we also had less illness. Now, there's a lot of factors, but that's kind of something that we see. And then this was what happened in 2017, 2018. That's when we had a lot of, we had a lot of problems, I guess, so to speak. But combined over the last 10 years, we've had 359,000 deaths associated with influenza. So when was the first official case in the US for coronavirus? So that happened in January 2020. Now, we've seen blood samples, and those blood samples have kind of told us that we may have had, the coronavirus here a little bit earlier than that, sometime in December, or maybe even earlier than that. But the first patient was found in Washington. The first official patient was found in Washington on January 2020. Um, and so if you look back here, on January 10, 2020, we only had 41 cases, and this was before the first official case in the United States. So how have we fared since then? So so if you look, um, basically, based on data from December 6, 2020, we've had 135,000 deaths in the last, I guess, 10 and a half months, if we take into consideration that official date that we start to see our first patient. And the projection is that we're going to get to 303,000 to 329,000 by December 26. So if we put all that into perspective, um, we basically could potentially say that we have not, like, we're not at 359,000, but in the last 10 and a half months, we're pretty close to it. So, and that's a combined total for the last 10 years. Um, and so if we were to rank it amongst the other leading causes of death, based on statistics in the United States. We have diseases, heart disease, as number one, malignancies is number two, and then accidents usually follow suit in 2017, 2018. But if we look at 2020 data in the future, we're probably going to see that COVID was ranked third based on the amount of deaths that we saw. That 200 and something thousand, close to 300,000, and so it's behind cancer but above accidents. And so that's it for part one. And follow suit with part two. And I hope you enjoyed this, and I hope it was informative regarding the virus. Please stick around for part two so that we can get a little bit more comfortable with the vaccine. Thank you very much.